This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution but cannot be resold, distributed, or displayed for profit. Copyright 2016, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is Palliative Care, addressing symptom management in pulmonary patients. Helen Sorenson is a registered respiratory therapist, fellow of the AARC, and adjunct faculty member at the University of Texas Health Sciences Center in San Antonio. Dr. Paul Selecky is the medical director of the Respiratory Care Department and member of the Sleep Disorder Center at Hoag Hospital in Newport Beach, California, and is a clinical professor of medicine at the University of California, Los Angeles. Neither Ms. Sorenson nor Dr. Selecky have conflicts of interest related to this presentation. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis.
Good morning and welcome to the AARC Current Topics in Respiratory Care. My name is Helen Sorenson and I am currently the chair of the AARC Palliative Care Committee. I'm an adjunct faculty member at the University of Texas Health Science Center in the Respiratory Care Department. I've been an educator for the last 30 years, respiratory therapist for 35 years. I'm just happy to be here today talking about our topic of palliative care. Before we get into that, I'm going to let Dr. Paul Selecky introduce himself.
Good morning, Helen. I'm a pulmonologist at a hospital in Southern California where we developed a palliative care program a number of years ago, going back to, I think, 1999. And beyond that, I've got involved with the development of the palliative care network at the American College of Chest Physicians. And Helen and I have spoken at the AARC meeting a number of times over the years about the issue of palliative care, ethical issues associated with that, and decided we would want to share our experience with some of our audience.
Absolutely. I think this topic is extremely important to both of us because we both feel that there's a disconnect between palliative care and hospice that well, maybe there isn't a disconnect. I think we want to have a disconnect between the two of them because there's so many people that believe that palliative care and hospice are the same thing. So there's a number of different topics we want to talk about today. But first of all, why don't we define it, Paul?
Palliative care, it refers to relief of symptoms, specifically release of pain and suffering, the key word being suffering, related to someone's onset of a chronic illness. COPD, for our field, is usually the number one focus for us, but congestive heart failure would respond in the same way, where the physicians are dealing with a disease that is progressive, and they begin to use medications, bronchodilators and the like, to make the patient with COPD feel better, keep them out of the hospital, get them to stop smoking, and then they're left with shortness of breath. Sort of this is a natural thing because that's part of the disease. Our concern is that's a major focus of the patient's care. Palliation is relief of suffering, and the suffering in this case is shortness of breath, which takes second and third role in many physicians' eyes. And so we're eager to share that news because there are many who feel that palliative care is for the patient who is actively dying in the last parts of life. And our point is that palliative care begins with a diagnosis of COPD. And it plays a major role near the end of life, but it is there all the time. If you look at the slide that shows the diagram, that when the patient first is diagnosed with COPD, we find that our focus is primarily on relief of the progress in the disease itself, to try to stabilize it, prevent it from progressing too fast. And then as the disease progresses on, then we find our curative therapies are ineffective. And so we rely primarily on palliative care. It allows us to then move into the next phase near the ends of life, which some may say is hospice care, but that word hospice scares people away, particularly patients as well as physicians. And ultimately, the last hours of life and beginning to prepare for the obvious outcome.
I think in the past there has been such a connection between palliative care and hospice and end-of-life care that maybe that's why we're not doing as good in palliative care as we should be, because patients are afraid. Right. When you say palliative care, they're thinking hospice. Respiratory therapists are afraid. When you say palliative care, they're thinking hospice. And I mean, preserving life at all costs is a big thing, and we want people to stay alive. And so I think it's been a hard sell getting people to disassociate palliative care from hospice, because they're clearly not the same thing. Hospice is when they have less than 6 months to live.
And the government will pay for what their needs are.
Okay.
That's the difference. But that's not the major focus of what we're trying to do. No. And trying to palliate the patient's shortness of breath in the beginning. But you consider in the suffering might be emotional suffering, spiritual suffering, where the patient is trying to make his way through his God as he approaches death near the end of life. Not just physical symptoms, but for a majority of us, dyspnea is just a part of every COPD patient's life.
Correct. What are some of the ways that we can incorporate palliative care into our daily routines in the hospital?
Well, it really begins, I think, with the education of respiratory therapists to start about the importance of this, and specifically even including it at the student level. Okay. I'm medical director of our respiratory care training program at Orange Coast College in Southern California, and we make a presentation on end-of-life care and palliative care to them as well. So we're planting the seed. Like in working with them, I give them a scenario that says, all right, you're taking care of this patient who is 75 years old, severe COPD, has been in and out of the hospital. You know her, she knows you, and while you're giving her treatment, she asks the question of you, am I dying? And I turn to the students and say, what would be your response? And universally, it is silence. They have no idea on what to say. So we can begin to teach them about communication techniques that allows the patient who has chosen that respiratory therapist to share her intimate fears, and they play a very vital role. So the respiratory therapist's role in this is clearly evident.
I know from my past experience that when the students would see palliative care only on the chart, which was maybe a little bit late, but they would come to me and show me the order and say, what am I supposed to do? And I would say, okay, well, let's talk about it. What are you doing now? Well, we're giving them neb treatments. Does it make them feel better? They said, yeah. And I said, well, then we're going to continue to do that. I said, do you think we want to do blood gases? And they kind of thought about it, and I said, are blood gases comfortable? Are they soothing? And they're like, no. And I said, then we probably don't want to do blood gases. Are they on oxygen? And they said, yes. Okay. Is the alarm going off? Yeah. Well, maybe we should take the alarm out of the room. Maybe that's not comfortable for them. And so they kind of got around to thinking, okay, but there's still, I think there's still a little bit of a fear when they see that order palliative care only, because we haven't done a good job educating our students on what palliative care is.
I agree.
I think the other thing that students, or not necessarily students, but respiratory therapists are a little bit afraid of going out on their own and saying, well, we need to do something here. If they don't have an order, they're a little bit nervous about even simple things like moving the bed up and down, getting a fan. They don't want to be caught doing something that they're not supposed to be doing.
But the primary person in that deliberation is the patient. And as we teach them, if the patient says, I'm going to move my tissue box from here to there, that's important to that patient, accept that if that's what they want to do, because they're so dependent on others to have at least one or two things of independence that they can still do. And so, as Dame Cicely Saunders, the founder of modern hospice, says, listen to your patient. He or she will tell you what you need to do. I found that so vitally true and important in our care of patients, to listen, to listen, to listen.
Something we need to really be focusing a little bit more on.
Yes. Physicians and patients often feel a little closer to the respiratory therapist or the nurse or the social worker that's involved in their care, feeling that for the physician to come in, it's changing now, fortunately, because we have an active palliative care team of 2 board-certified palliative care physicians, nurse, social worker, chaplain, and it's now an accepted thing. As soon as anybody's in distress, call palliative care. So it's a culture that has grown in our hospital over time, but it took a long time to do that. And other hospitals can do that as well.
I think yours would be a good model for other hospitals, because I'm pretty sure that not a lot of hospitals are doing that right now. And maybe it's a time constraint, maybe it's a money constraint, maybe it's lack of somebody in the hospital pushing for a palliative care committee.
That's the way it starts. I like to use an analogy from the movie Field of Dreams, where Kevin Costner develops this baseball field in the middle of his cornfield, and the phrase was, build it, they will come. Just find yourself a physician champion in palliative care to come on board, and he will attract others. And so build it, they will come. That's what our experience was. There was just a handful of us. We should find out what the interest is. I sent out a letter to all the medical staff, and I got 50 physicians saying, I want to be involved. We should have done this long ago. So I think the needs are perceived well, it's just the action that falls behind.
I think that's a wonderful message to our audience here. If you're working in the hospital, find a champion for palliative care. And I think you'll find a lot of other people that are interested in getting involved in it, because it truly is something that makes a difference in a patient's life if they don't have the horrible symptoms when they're dealing with a chronic or terminal disease to begin with. Some of the other things that I would like to discuss, we've talked a lot about COPD.
Yes.
And I think for the most part, our students understand the symptoms of COPD. What can they do for the shortness of breath? What can they do for the anxiety? And I agree, it's sometimes even just reaching over and holding their hand while they're having the nebulizer treatment calms them down. And I have actually often thought that respiratory therapists may be at the bedside more than a lot of other health professionals there. We stay there with them when they're doing their treatments, or we should stay there with them when they're doing their treatments. Doctors come in, talk to the patient and go out. Nurses come in, do what they have to do and go out. But we stay there. And we can see kind of if there's anxiety with a patient or if they're in pain, and we need to be asking, are you in pain? And if they say yes, we need to go get the nurse and see if there's an order for pain medication. Sometimes patients aren't willing to talk to other people, but when they get to know you, they may be a little more comfortable with saying, yeah, I really am struggling today.
That's my point about mentioning with the patients, ask the therapist, am I dying? They would only develop that intimacy to their own family perhaps, and sometimes even not there for fear they would scare their family.
But another area that I don't think gets discussed too much is palliative care in children. And I've been able to read a lot more recently about palliative care in children, and I think the one disease that hits us hardest as a respiratory therapist is cystic fibrosis. Back in 1979, when I had first started in respiratory therapy, I worked at a small community hospital, And a young girl, she was 8 years old with cystic fibrosis, had been transferred back to our small community hospital from a larger institution because she was dying and the family wanted her to be close. I had not been there during the day with her, but I was on call that night, and I got called back in about 9 o'clock at night. And I went in, and she was, I can't even call it crying. She didn't really have enough air to cry, but just help me, help me, help me. I can't breathe. And I had no idea what to do. In 1979, we had oxygen, we had bronchosol, we had mucomist, we had isopril, and we had atropine. And I kind of eliminated what I wasn't going to use, but I just felt so helpless. I had children at home that were her age, and I didn't know what to do. And I know we've come a long ways in cystic fibrosis now. But those children know from the time they're born that this disease is probably going to shorten their lifestyle, shorten their lifespan. And I think in most places, the palliative care or the cystic fibrosis team usually takes care of these patients. But when the cystic fibrosis team is not there, I think respiratory therapy is the one that has to step up with the palliative care. And I'm not really sure they're comfortable with that. One of the articles that I read about cystic fibrosis in pediatric patients stated, and it was talking about the use of opioids, and they said that 10 days before the patient died, only 1% of the people in the study had been given opioids. But 5 hours before they died, 95% of them had been given opioids. And I guess my question is, why wait?
Right.
What is it about opioids that are so helpful, and why are we so afraid to use them?
Well, we do the best we can, whether it's cystic fibrosis or COPD patients, to make them feel as comfortable as possible, particularly shortness of breath. Unfortunately, many caregivers realize, but you have this disease. Of course it's associated with dyspnea. There's nothing more I can do. You have advanced lung disease, whether it's a child or whether it's an adult with a different diagnosis. But we try all the medications everybody else has tried. And if you get the issue that opioids suppress the sensation of shortness of breath. But over the years, there's been fear, particularly in the adult community, that if they get an opioid, they will slow their breathing process. They might even die. But now there's a whole national awareness of the fact that we can treat the symptom of dyspnea. I point out to the students, if a patient fell down and broke their hip, brought into the ER, and the diagnosis was made, the physician wouldn't hesitate to give them opioids to relieve their pain. If the COPD patient came in with severe shortness of breath, many of the emergency room physicians feel that they have done the best they can with the patient is short of breath because of their COPD. But however, there's that one lasting addition that can be helpful, and that's opioids for the suppression of the symptom of dyspnea. The disease doesn't get any better, but it makes the patient feel much more comfortable. The American Thoracic Society has approved the use of opioids in palliative care in advanced lung disease or heart disease. The American College of Chest Physicians, the American College of Physicians have all published their guidelines, and we would like to make sure that all the caregivers of these patients need to know what those guidelines can say to them and give them support.
What is the best way to deliver opioids to our patients?
Parenterally or orally. The thought over time has been, well, why not an aerosol? That makes sense. We have a patient who has lung disease, and if we have them inhale opioids instead of giving it by pill form or intravenous, that will get directly to the effect like we do with bronchodilators, for example. But the key part of the sensation of dyspnea is a neural device called the parotid body that gets its treatment of dyspnea systemically. So if the patient is going to get it by inhalation, it might be helpful, but it has to be evaluated time and time again to see if it's being very effective. Because the guidelines that have been published that I just mentioned refer to the ideal way is giving it by either orally or parenterally. And dose is all laid out in the publications, enough to give the patient an edge off their dyspnea, but not to suppress them too deeply.
Okay. I think that's extremely important that all healthcare providers are really aware of the best way to give opioids and when to start them, and waiting until they have 3 breaths left and they've taken 2 is probably not the time to start the opioid therapy.
Our clinical nurse specialist, as part of our palliative care team, came to us from 28 years experience in England, where she ran a breathlessness clinic, and the patient with severe COPD would come in and get their 1 or 2 tablets of morphine and be gone for the day and come back the next day. So the dose was controlled, but it was openly given as you would give a pain medication for someone having pain of various kinds. So they are 20 years ahead of us. We now, however, as I mentioned, have board certification in palliative care. We're moving into a new arena, focusing on the patient's suffering and how to resolve it.
I just read an article a couple days ago about a breathlessness clinic in South London, and they had a number of hospitals that participated in that, and they found that indeed it did reduce the symptoms, and the breathlessness clinic, not only did it reduce the symptoms, but they were able to exercise more. But one thing I found interesting was that it reduced the symptoms in COPD and in chronic pulmonary disease, but it really didn't help that much in lung cancer. So, but their breathlessness team had physicians, nurses, the respiratory nurses over there. They don't have respiratory therapists yet. We're working on that. The occupational therapist and the physical therapist were all part of the breathlessness team. So it wasn't just,
yes,
you know, it was pretty global. It was multidisciplinary what they were doing with the patients.
It's wonderful to hear what their experiences are and try to incorporate it here.
Yeah.
You're familiar with the article that appeared, I think, in the New England Journal about early introduction of palliative care in lung cancer patients.
Yes, that was really interesting because it was a randomized controlled trial. And it was on a number of patients with non-small cell lung cancer. And all of them got standard oncology care. All of the people in the study got standard, the best oncology care they could get. But half of them were randomized to early palliative care. And the ones that had early palliative care had fewer symptoms, they had less depression, they had a better quality of life.
And they lived longer.
And they lived longer. And that was
Amazing.
not even an outcome they were looking for. What they were looking for was a better, better quality of life. So a randomized controlled trial makes a big difference. And I think we do need more research in end-of-life care. And there's examples out there of how it can be done.
So we go back to what we talked about earlier. The question of when to begin palliative care approach, in my opinion, it's in the time of the diagnosis. The needs for relief of suffering may be small at that time, but as the disease progresses, palliative care has been involved in helping the patient to accept what's happening, going into advanced care planning for the future. Do they want to be on the ventilator or not? Those kinds of things we have conversations with, but they're kind of spotty. Not everybody hears the same message. Because it can be striking when the patient is short of breath and they're very much afraid. They don't want to suffocate, and we need to give them that assurance, we will be there with you. Even when we just stand, the gift of the power of presence, you touched on this earlier. Mm-hmm. When you don't know what to say, Andy Rooney has a phrase, don't just sit there, do something. In other words, instead of don't just stand there and do nothing, then in fact just holding the patient's hand, as you said, and just standing, and let them become more at peace because they know you're there.
I had a situation when I was a clinical instructor many years ago, and I was in the room. The student was giving therapy to the patient, and I was holding the patient's hand. And then I had to go do something else, so I went away and I came back again, and the student was giving the therapy, and he goes, "Mrs. Sorenson, go over and hold her hand again." And I said, "Why?" And he said, "Just humor me." So I went and held her hand, and he said, "Okay. Now go stand out in the hall and stay there for a couple seconds. I'm fine, I'm not going to do anything. And then come back in again." And so I did. And I came back in again, and he said, "Now hold her hand again." And I said, What are you looking at?" And he said, "Her heart rate. Every time you hold her hand, her heart rate comes back down." And we didn't know that this lady was even aware that we were there. She wasn't comatose, she just wasn't very responsive to us. And I was very proud of the student for noticing that, but I was, after that I told my students, hand holding is not always optional, sometimes it's mandatory. If they're anxious, they've got the nebulizer in place, they're doing fine, hold their hand. Let them know you're there.
You're reminding me of an experience I had way back in training when we had patients with severe asthma being admitted. We'd give them intravenous theophylline to relieve their symptoms. The treatment of asthma has changed since that time. But we were taught to sit at the bedside with a needle in the vein and slowly over time introduce the medication. And as my professor said at the time, what's probably most effective in relieving that patient's shortness of breath is you're sitting there at the bedside while you gave the drug. It wasn't the drug, it was your being at the bedside. And I thought, aha, we humans need to connect with one another.
Yeah. Why do you think we have so many barriers to palliative care?
Well, I think it's relatively new. It's in training programs now, but it wasn't long ago. So physicians are a little hesitant, even though I will tell them, but there are national guidelines, and I rattle off the guideline organizations that have come out. What's happened that even in terminal weaning, where the patient is going to be taken off the ventilator and allowed to have a natural death, that the intensivists feel more comfortable if the palliative care team is there to help them, because this is what our team's expertise is. So I think it's lack of training, it's fear of the unknown, especially in the use of opioids. Gee, it never was part of my training, I don't know what to do. Well, here's the literature, be a champion into your own team. And so I think it's coming along slowly. We now have a palliative care network in the American College of Chest Physicians. We have the round table. You may want to talk about that for the respiratory therapists who are involved in care of patients with dyspnea and providing palliative care.
One of the things that I just posted, and this was 2 days ago, it was from the Committee for Advancement of Palliative Care, and there was there was a list of triggers. There were the primary triggers and the secondary triggers that should initiate a palliative care consult. And I was surprised at some of the triggers on there. One of them was long-term oxygen use. But if you think about it, if they're on long-term oxygen use, they have a chronic pulmonary disease.
Of course they do.
And they probably need a palliative care consult. They may not need palliative care at the time, but they need somebody to sit down and talk to them about what palliative care is. Because a lot of our patients think hospice and palliative care are the same thing, and they don't want to go to hospice because that means they're dying. And if they think hospice and palliative care are the same thing, there was another there was another study, and that was published in the Chest Physician newsletter. It was a medical student. Basically, the scenario she gave to both of them was identical. But in one case, she said the word palliative care, and the other case, she said the word supportive care. And so as she was describing the therapy that they could have and describing their availability for the therapy and talking to them about it, she then asked them, is this something that you think you might like? And the ones that heard the term palliative care said, no, I'm not ready for that.
Right.
The ones that heard the term supportive care said, yeah, I believe that might be something that I could benefit from. And the script on both of them was identical except for the word palliative care and supportive care. So maybe we need to do a better job of educating people on what palliative care is.
When we were formulating our team, we did a survey of patients coming in, and our team went and visited them sort of randomly. It was part of our program for one of the medical groups associated with our hospital. And they were welcomed at every patient's bedside. And the thing that the patient was most interested in was advanced care planning. Just they knew they should have a, quote, living will. And so it was very well received. But it's not necessarily waiting until they have physical symptom is out of control. And now they can't think of advanced care planning because they're so focused on the fact that I am short of breath. I need support now. But you're right, palliative care is thought to be end-of-life care only. And if you look at the whole spectrum, end-of-life care doesn't come in until the last several weeks or months of life. And sometimes patients have times to plan, sometimes they don't. It's interesting, in our pulmonary rehab program, we routinely go through advanced care planning exercise with our patients and their staff and their support and their relatives, etc. And it was very successful, but the cardiac rehab team, patients weren't as interested in that. Figured I had my heart surgery, now I'm fine. I had my heart attack, now I'm fine. Not recognizing that what they have is progressive. As we know in congestive heart failure, it's another model that can be used. So it's all in perception. And the patient just wants to push that negative feeling back further along and not too soon.
Because they too feel that palliative care and hospice are one and the same thing.
Yes, unfortunately.
Okay. Okay. What is the makeup of your palliative care committee? You have physicians and nurses? Do you have?
We have actually 1.5, but we'll say we have 2 board-certified physicians, board-certified in palliative medicine. Our clinical nurse specialist who comes to us from England, 3 social workers. They're kept the busiest because we now have an outpatient clinic that follows the patient. Most of the time we see them for the first time in the hospital where they're admitted because of some crisis. And then we follow them afterwards at the physician's discretion. And the majority of the time they'll say, sure, help me take care of the patient. You're there, you can spend a lot more time. And then we bring in the chaplain when that's needed and appropriate. So it's a team that's very busy. When we first started our program in 1999, we saw 50 patients in the first year. Now we see 80 patients per month. Wow. And it's growing. So we need a bigger team at this point because the role of palliative care is much more readily accepted at our house than it was in the past. But that took time, a lot of education, lectures. The team would give to our medical staff. We'd bring in experts for the medical staff.
I know that respiratory therapists, I don't think traditionally respiratory therapists are on too many palliative care teams, but I think this is something that we might need to be a little more proactive about, and maybe going to the hospital's palliative care committee and saying, we would like to be involved. And if you've got that many referrals, you're very, very busy. And I don't know that a lot of respiratory therapists would be receptive to that. I know respiratory therapy departments are busy in themselves. They're busy doing what they do. And when we have our time in the patient's room, we can do the best we can to comfort them. Some of the therapists that I've talked to, when I've asked if they do palliative care, they're like, oh, well,
What's
no,
that?
What's that? And I said, well, have you ever adjusted a patient's bed when they're uncomfortable and kind of sat them up or laid them down so they're not in pain? And they said, well, yeah. I said, have you ever got a patient a cup of coffee when the therapy is over because they like their coffee in the morning? Well, yeah. I said, did it make the patient feel better? Well, yeah. I said, that's palliative. I mean, if you look, like you said in the term for palliation, it's comforting them. It's making them feel better. It's not curing them. It's just making them more comfortable. How hard is it for us to ask the patient when we're in there, are you in any pain? And if the answer is yes, go find the nurse to see if there's an order for pain medication. Some patients are afraid of nurses. I have two sisters who are nurses that I think there's sometimes a reason for being afraid of nurses. I'm afraid of some nurses when they come in the room. But I think that we're just as capable of asking them that. One of the things that I'm going to talk about, which is something that I found was fairly new in palliative care, was asking a patient about spirituality. And that's not something I've ever been comfortable doing because I didn't think it was my place. I know when they come through admissions, they're asked what their religion is, and they are asked if they have any spiritual needs. And when I had back surgery, I went through admissions. They asked me my religion, and I told them. They asked me if I had any spiritual needs, and I'm like, no, I'm fine. Until the day after my back surgery, and I thought, gosh, I would sure like a visit from my minister or somebody just to hold my hand. I was terrified of using the morphine. I didn't want to push that little morphine pump because I thought I was going to overdose and fall asleep and never wake up again. I needed somebody to talk to. So for a respiratory therapist, after the patient is back in their room again, you know they've been asked that question, but if the therapist would say, do you have any spiritual needs? And if the patient says yes, then go find a caseworker. Go find a chaplain. I certainly don't want my students, or I keep saying students, I was an instructor too many years. I don't think therapists are capable of, or no, they're capable of, I don't think they should give spiritual advice. But I think they could certainly find somebody that would call somebody that would help them.
Well, we teach them in communication techniques to give feedback to the patient, like the one I mentioned before, am I dying? Mm-hmm. Is to say, well, what are your thoughts about it? And in other words, take the same symptom and give it back to the patient. So I presume we could do that with spirituality as well. Mm-hmm. And asking the simple question, how can we help you? Physicians will vary depending on their own comfort level. At a round table that we had in which I was asking about the role of spirituality and spiritual care for the patients, one physician said, I always call the chaplain. And that's only if I have a need. We're at the other end of the spectrum with a physician who is very spiritual himself, said, of course I need to know what their beliefs are. And is it important? Are they part of a faith community? How would it affect what I'm going to do for your care, like a Jehovah's Witness, for example? So it depends upon the individual physician, and you look for the champions and support them, and more will come along. Build it, they will come.
I like that. I like that. Another thing that I was reading when I was getting ready for this presentation was palliative care in alpha-1 patients. We don't talk about that too much. And what surprised me was when I looked up the articles and I read, lung volume reduction surgery is considered palliative in alpha-1. And depending on the type of emphysema that they have, depending on where the location is. And I know they've done a lot of studies on that in the NET study, I believe it was. But they were saying that a lung volume reduction surgery would relieve their sensation of dyspnea or bring it back down to a manageable level that would last for 2 to 3 years. And that was not something I was aware of. Do you do a lot of treatment with lung volume reduction surgery in your hospital?
That has evolved over time, and now it's rarely done. I mean, several hospitals in the area have been geared up for those kinds of surgeries because they can be very feeble, but we haven't done one in some time.
And it's a very narrow diagnosis that they have to have.
I don't remember the details. They had to have they look for the criteria that would make it too dangerous to have the treatment. And it's a low diffusing capacity, for example, is one of those I recall. I don't remember the others at the moment. Yeah. But it's interesting, but you're right. I mean, if it's relief of suffering, various kinds, whether it's physical or spiritual or emotional or psychosocial, those are needs the patients have. We want to take care of the total patient, as we believe we are doing, but patients can often teach us on how we can do it even better.
I think as a respiratory therapist and a pulmonary physician too, we are more likely to focus on COPD most of the time. But we can also expand our concept of palliative care to other areas other than respiratory too. How are we giving palliative care to our patients that are going into surgery? How about our patients that are on mechanical ventilators for whatever reason? It may be kidney, it may be heart. I think that's another area that we need to maybe start addressing, is palliative care across the spectrum of patients in the hospital, not just age spectrum, but diagnosis spectrum too, to make sure that people understand that it's not just shortness of breath we're trying to take care of.
Yes. The board of directors of our hospital put out a resolution that all patients being admitted to the hospital will be made available to undergo palliative care for any of their needs. Now, whether it moves into action is another story again, but we're trying to make it as open as possible. And if we get patients, and healthcare givers ask the right questions, you'll get the answer that you need. Okay. But you're right. I mean, we focus on COPD because this is what we deal with every day, and where our needs are. But I guess I need to apologize. We don't have respiratory therapists in our palliative care team. We do a counterpart of that. We have respiratory therapist navigators.
Okay.
We have 2 very bright respiratory therapists who visit every lung disease admission to the hospital and begin to interact with them and teach them at the bedside. And so in that sense, they're providing palliative care in the care of these patients. And the goal would be to get them into pulmonary rehab as they get discharged, and to follow them after that over time, working through our Better Breathers Club of the American Lung Association. Okay. And so it's been very well accepted. Our average length of stay has decreased. Our readmission rate has decreased because the patients are getting a constant flow of information and support, and have been very well received, so we're very happy about that program.
And I think that's maybe something other people need to understand, that there are benefits. There are benefits to the whole hospital. Yeah. Like you said, fewer readmissions, shorter length of stay. I think that hospital departments, many across the country, are sort of right now reeling from the readmission rate and trying to figure out what they can do to fix that, and putting all of their energy there. I think many hospital or respiratory therapy departments are probably maybe a little bit understaffed, and you have X amount of things to do in Y amount of time. And I'm presuming that the initiative or willingness to jump up and say, oh, let's start a palliative care committee at the hospital, is not going to go over real well when you're already overwhelmed with everything else that you're doing. However, I think the benefits in the long run that you're seeing in your hospital is making a difference.
And there's been a lot of published studies showing that palliative care reduces admissions, reduces readmissions, has cost savings in medications, all the patients in the hospital. But you got to spend the money up front and get the personnel in place. And our palliative care team is now being stretched quite thin, and we are trying to work on getting financial support for extending that group. We now have a fellowship program in association with the UC Irvine nearby us. And so it's an exciting field.
What are some of the biggest barriers that you see?
Physicians.
I didn't want to say that.
No, I mean, they're the captain of the ship. That's how we have been trained. We're responsible for everything. It all has to go through me. But number one, the physician doesn't have time to sit with the patient any length of time, doesn't have the knowledge and expertise the way respiratory therapists do about the care of their patients and how to get them to feeling better. They know about the importance of personal breathing and abdominal breathing and things of this nature, but it's the respiratory therapist being at the bedside that makes the whole project work. Mm-hmm. And some of our patients, some of our physicians readily call us. Others say, no, I'll call you when I need you. And the sooner they learn about the benefits of it, the more ready they are to ask for help.
Do you think that there's in their mind, if they talk to the patient about palliative care, the patient will hear the word hospice, and then the patient will say, well, if they're talking to me about palliative care, they must think I'm dying?
And then the therapist will get, or the supervisor will get a phone call from the patient's physician saying, what was that respiratory therapist trying to do to introduce? Yeah. They're not dying.
And trust me, that's not a place we want to go.
So you just get pushback just once and you're reluctant to ever say it again. Yeah. Unfortunately, that physician is missing out, his patients are missing out because it can be so much better in how it's done.
I do think that we're getting closer to
universal acceptance.
Well, I think we're getting closer. I think even in the healthcare field, we're talking more about palliative care. It's getting, I think the younger doctors, I shouldn't say that, but I think the younger doctors who are going through medical school now are maybe getting a better idea of the difference between palliation and hospice. Is palliative care reimbursed at all? I know hospice care is reimbursable, or they get funded if the patient goes to hospice. What about palliative care? Is there any funding for that?
Well, I guess it was just released not too long ago that Medicare will offer payments for end-of-life care kind of discussions for the time the physician spends with the patient working out advanced care planning.
Well, that's very hopeful.
Yes, it is, because that's been an obstacle. I know it needs to be done and I should do it, but I don't have the time because I have to see this patient, this patient, this patient. Mm-hmm. And so that's a big help to recognize that's a specific step to take. It needs to be done in all our patients. And in the past, they were concerned about the death group or something, that you'd have a death panel where the patient would be evaluated as who would get aggressive care, who wouldn't, and that was poorly presented and not well received, rightfully so. Mm-hmm. So I think that we're getting off on a better foot at this point.
In the future, do you see more and more palliative care committees in the hospital and more people getting on board so that we have a clear separation of this patient is likely going to die within the next 3 months, 6 months. This patient needs extra services that the government will take care of. Versus this patient, wow, They've just been diagnosed with a chronic disease. Chronic disease usually involves symptoms. What are we going to do about the symptoms? And if they could just separate the patient is dying from the patient has symptoms and clearly say, this is hospice, this is palliative care.
Yes.
How close are we to that?
Oh, we're just at the beginning steps. Basically, our experience and many others have shared with me a similar experience that the physician gets help from palliative care and that'll make it much more ready for the physician to ask for that on the next patient and the next patient over time. They get support that they feared was going to be taken away from them, and now it's added. The patients are happy, the patient's family are happy, and they thank the doctor for providing that special person from the palliative care team that came in and talked to you. It would help if the physician would say up front to the patient, now I'm going to call in a team and they're going to begin to assess and help us with, help me with your care.
Okay.
Build it, they will come.
From a respiratory therapist standpoint, very often the topic, I shouldn't say very often, but occasionally, the doctor is in talking to the patient. The doctor asks the patient if they have any questions. The patients are probably afraid of the physician a little bit. They don't want to bother the physician. They know the physician is busy. So the physician walks out, the respiratory therapist walks in, and the patient looks at the therapist and says, "Am I dying?" It's a very difficult position for respiratory therapists to be in, one that I'm sure they would rather just say, no, you're fine, which they're probably not, or, yeah, the prognosis doesn't look very good, so yeah, the doctor's probably right. Help us out here. What's a good way to deal with this situation, Paul?
Well, as you touched earlier, respiratory therapist spends more time at the bedside than probably the nurses, social workers, and others, because they're locked in with that nebulizer treatment, for example, would be one reason, but a lot of palliation as well. And when I ask the students, what would you say when patient confided in you this intimate fear, am I dying? I must say my own mother asked me that when she was dying from chronic hepatitis C and liver failure, and despite the fact I teach this subject, I was at a loss as to what to say to my own mother. And I said, well, Mom, I don't know, but you've been pretty sick. And that's the kind of phrase I think that we can say to our respiratory therapists to talk to patients as well. The technique of giving them a mirror image back of, say, do you think you're dying? Well, the patient may respond and say, well, I'm not sure, that's why I asked you, dummy. But in fact, it often opens the door, oh, the therapist is willing to listen to me. It's perception checking, or does that make you, when the patient says, am I dying, does that make you afraid? Is it, no, not really, or yes. I just need to know what the future is, so I can start planning for my family, things of this nature.
Another physician told me once that, because this has been something that's bothered me for many years, what is an appropriate response? And another physician said, well, if they're asking you, am I dying, you could say, well, we hope not soon, but that's maybe something we need to prepare for. And are you prepared if something would happen? And if they say, well, no, then if you got an easy segue, well, is there somebody that you would like to talk to? Or do you need to talk to your family about this? Or would you like to talk to a social worker? Or would you like to talk to a care worker? Because of the time we have in there, I think we have the ability to maybe get a conversation started and maybe get them thinking about, well, maybe I should call my children and kind of let them know. no, you're not dying today, but none of us are going to get out of this world alive.
But you don't know if today isn't the day.
No, no, you don't know.
One of our elderly ladies who died in the hospital asked the nurse, I want you to put on some makeup because I'm dying today, and put my teeth in. She's going to meet her maker looking as splendid as she could.
I had an elderly lady one time that we were in there giving her therapy, and she asked if breakfast was coming, and I said, yeah, the tray should be here pretty soon. And she said, I want chocolate cake. Today's my birthday. And the students are like, well, and I'm like, really? You want chocolate cake? Today's your birthday. She said, yeah. And I'm not going to have any more birthdays. So we called the cafeteria. She got her chocolate cake, and she died that night.
Wow.
And she didn't seem all that sick when we were talking to her. She didn't look well, but how many times does a patient ask you for chocolate cake for breakfast? And it was so unusual that I thought, well, if today's her birthday, she can have chocolate cake. And the students were like, for breakfast? And I'm like, but it was one of those situations that I'm glad she asked. I'm glad she told us why.
Absolutely.
And I'm glad she got her chocolate cake.
I think that's the point we haven't made enough in our discussion today, how rewarding providing palliative care is to the giver.
Yes.
I mean, you go home and said, we accomplished something today.
Yes.
I feel good.
Yeah.
I was able to hold this patient's hand, and it seemed to make a difference. And they share their successes with their family at home, and their failures, or I didn't do so good. When I asked my therapist again, my students, am I dying? I got one time an answer. Young man said, not on my shift. I said, that's not too cool, but that was his quick response to get away from his own tension, I suspect. But they began to pick up what to say. And a young lady in front of me sitting, listening, just said I would hold the patient's hand. I thought, there you are. You got the message, the power of presence. Yeah. Just being available. I mean, you can stand there and do nothing, say nothing. And the patient may just open up. You might even sit down next to the bed, but more likely you're there at the bedside. And it's a rare opportunity because I think we're in a profession where it's amazing how patients would reveal to us intimacies they wouldn't share with their own family, of experiences, fears, and depending on what was discussed, it would be appropriate for the therapist to report that to the nurse or to discuss it with the physician if they know the physician and work with that physician before. Say, Mrs. Jones in room 20, she's afraid she's going to die. And that's what the word is, she's afraid.
Yeah.
Another Mrs. Jones may say, I just need to know.
Yeah.
Is it soon? Am I going to go to my granddaughter's college graduation in Ohio? Maybe not. So I think that it's a grand profession. We've become part of this, and reminding that this is a profession. It isn't just a certification to do something.
And I think my message to respiratory therapists would be there. Be there for the patient. You have the time while you're in the room to ask them a few questions. If you feel like something is amiss, if you're asking if they feel okay, but you can see that they're agitated, that they're moving around a lot in bed, that they look like they're in pain, talk to the nurse, see if there's anything that the nurse can do, or go back and talk to them. But take the time that you have when you're in the room to visit with the patient a little bit, or just be there for them. And if they're taking their neb treatment, hold their hand. You're going to put the pulse oximeter on their finger anyways. Just hold their hand a little bit. If you are not a member of the Palliative Care Roundtable, I would love to have you become a part of the conversation with us. You can go to AARC Connect and join the AARC Palliative Care Roundtable, of which Dr. Selecky was instrumental in helping us get that going, for which we are very grateful. One of the latest things we posted, again, I want to mention the triggers to palliative care, the primary and secondary triggers that would initiate a palliative care consult. And if you don't have a palliative care team in your hospital, it doesn't mean that you can't at least talk to somebody about getting palliative care going. We don't have to have a palliative care team to do palliative care. We're in the room. If they have symptoms, let's see what we can do to relieve their symptoms or find somebody that can relieve their symptoms. Let's not be afraid to talk to the doctors. I was afraid to talk to doctors for the first 20 years as a respiratory therapist. They were up here and I was down here, and I was terrified of doctors. I still am a little bit nervous around doctors that I don't know. But let's think in terms of what's best for the patient. Let's think in terms of, if this was me laying in bed and I was in pain, what would I want done? Who would I want to talk to? So.
And in fact, the physicians, if they were given a little nudge by the respiratory therapists, I mean, with severe shortness of breath, the therapist mentioned, maybe I'd consider a little morphine for this patient's shortness of breath to make you feel, because Dr. So-and-so does that for his patients, and it's very well received. And not saying you should be doing it, but saying just.
But a little nudge. You heard it. You heard it from Dr. Selecky. You can give your physicians a little nudge on palliative care. Thank you all for joining us today. We have enjoyed visiting with each other and hope that this is valuable to you, and thank you.